All right. Hello, everyone. I'm Anthony Minke. I'm a nurse practitioner with the trauma service here at Sanford and Fargo. A little bit about me. I've been a nurse for 10 years now and a nurse practitioner for the last 4. Um, and I'll just click the.
Oh, yes.
So kind of objectives for today, talking about the initial assessment for breathing in the trauma patient and recognizing those true emergencies, understanding which diagnostics can be done and the interventions for each type of breathing problem. And then understanding the trauma mechanism and how it relates to injury. I like to first think about look, listen, and feel. First and foremost, to have breathing, you first need to have an airway. So recognizing that you need a patent airway first before you go into breathing, because airway obstruction, inadequate ventilation can lead to hypoxia and death within minutes. Just kind of looking at your patient first, you're assessing their respiratory rate effort. They breathing fast or slow? Do they look like they're struggling? Kind of inspecting that chest wall, looking at the thoracic wall for symmetric movement. Is there any signs of external trauma? Is there seatbelt spine ecchymosis, or kind of the area where the seatbelt may be? Is there any holes? So we're looking at penetrating trauma, looking at any open wounds. So not always present is those descending neck veins or deviation in the trachea, but in severe cases, tension pneumothorax can cause that. And then also looking too at their mentation. Are they awake? What's their GCS? Are they oxygenating well enough to be awake? And do they have any signs of head injury? And then looking at, O2 saturation, cyanosis of fingers, lips, face. With a stethoscope, listen for any absence of lung sounds. Absence of lung sounds could be related to a pneumothorax, hemothorax. And then getting down and feeling the chest wall. Does the patient elicit any tenderness? Do you feel cracking sensation of subcutaneous emphysema? Does the chest wall feel unstable? Do you feel movement different in the sternum or the ribs? So when we go to understanding mechanism, first, what type of trauma happened? Anticipate injuries based on mechanism. It was a highway speed motor vehicle collision versus a low speed. And then thinking there too, was the patient restrained or unrestrained? Then we think about falls, standing versus falling from a height. And then we wondered too with any loss of consciousness. Back to the motor vehicle collision, thinking about the vehicle deformity. Was there prolonged extrication? Was there significant intrusion? Was there any death in the crash? That something can elicit more traumatic injuries in those patients. Thinking about head injuries too, decreased respiratory drive can cause inability to maintain your respiratory drive, whether it be from intoxication or head injury. Switching to penetrating trauma, anything that invades the chest wall via a stab wound or gunshot wound, for example, thinking that this can puncture the lung, cause air to escape into the pleural space, which could lead to the pneumothorax. And then thinking about penetrating trauma, impaling injuries, blast injuries, industrial accidents. And then your higher energy gunshot wounds. These can cause significant bone and soft tissue damage, and this can lead to problems with ventilation. Something that I see more of, rib fractures. If it hurts to breathe, you're not going to want to take those big, deep breaths. That can make it difficult to maintain secretions, to cough and clear those. And is it a single versus multiple rib fractures? We'll talk about flail chest later, but also recognizing too that any of the lower rib fractures can be associated with intra-abdominal injuries. And then a little bit about spinal cord injury. Depending on the level of the injury will depend on where your deficits are, recognizing that the higher level of injuries may have impairments with the diaphragm, which can make it difficult to maintain your airway and breathe. And a lot of us take care of older population, some considerations for the geriatric population. Some of the anatomic and physiologic changes that accompany aging, they're at a greater risk for injury and death. This is due to the impaired ability to respond to the stress of injury. Most studies use 65 years old as what is defined as geriatric. Some define it as 70. Just knowing that older adults may have a reduced vital capacity, functional residual capacity, and forced expiratory volume. They can also have a decreased lung chest wall compliance. Treatment for these patients, aggressive airway management. This is securement of airway assistant with breathing. Some patients may require intubation, mechanical ventilation. Some may require BiPAP, non-invasive ventilation, but recognizing that that would be contraindicated in your facial trauma patients. And moving on, diagnostics. A few of them you can consider in the trauma bay, or depending on your facility, a chest x-ray can be an easy way to identify a urgent situation. If available, CT scan or sometimes ultrasound. I'm kind of just focusing on, the breathing problems. Going over to talking about pneumothorax. This can happen, blunt, penetrating. We won't talk about it spontaneously, but in regards to trauma, blunt trauma, penetrating trauma, or it can be caused by medical procedures. Talking about blunt trauma, car crashes, falls, hits to the chest, and then underlying rib fractures with damage to the chest. These can be seen on chest x-ray. Looking at the different types, closed pneumothorax, open, and tension. We want to recognize the ones that are going to cause death very urgently. Tension pneumothorax and massive hemothorax, are immediate threats to life, and those should be identified early in the primary survey. This is going to be signs of hypotension, dyspnea, ipsilateral decreased breath sounds. This should be treated with a needle decompression prior to obtaining injuries, if resources are available and it's appropriate, directly to chest tube insertion or finger thoracostomy. Thinking about other types of pneumothoraxes, your small ones, they may be monitored, they may be stable, the patient's asymptomatic. In 5 to 10% of these patients, the occult pneumothoraces expand and can become clinically significant. If you have an x-ray that shows no pneumo, after maybe your patient's intubated and gets that positive pressure, something that may now kind of rear its head and now be a problem. So identifying that positive pressure can change things. And then open pneumothorax, this is air that enters the chest cavity via an open wound. You can also hear it of a sucking chest wound. Quick treatment for this would be to place an occlusive dressing on 3 sides to allow air to exit but not to enter and cause expansion. Talking a little bit about hemothorax, so similar, but now there's blood involved. Injury to the lung parenchyma, disruption of the vessels, multiple rib fractures. A tube thoracostomy can drain this, looking at the amounts of blood initially that comes out, and then also identifying any blood that comes out over the next few hours. And what does that blood look like? Is it look like old clotted blood? Is it fresh? Look like fresh blood? Does it look like just fluid? And some of these patients may require surgery to drain the chest and wash it out. In an x-ray, an upright x-ray, 200 to 300 mils of blood is what is needed to be sufficient in the pleural space to detect a hemothorax. Remember, patients that have multiple rib fractures in multiple different places, You hear of a flail chest, and this is 3 or more adjacent ribs in 2 separate places. That piece will float, can move paradoxally, but it may not always be seen if your patient is shallow breathing due to pain. Other things that I did not kind of talk about would be pulmonary contusions, lacerations, tracheobronchial injuries, but understanding that those are also involved in the problems of breathing. Talk about rib fracture treatment. Not everybody is admitted to the hospital. For some that are with multiple rib fractures, comorbidities. I always tell my patients, if you break your arm, break your leg, you can not put weight on it. You can put it in a cast. Hard thing with ribs is you can't not breathe. So the encouragement is to be able to cough and deep breathe, with multi-pain regimen, around the clock Tylenol, NSAIDs if applicable. I know certain patients can't have that for whatever comorbidities, or maybe they have a coexisting head bleed. And then some do require opiates for that breakthrough pain. And aggressive pulmonary support. Aerobica, incentive spirometer is the best way to get your patient to take those big deep breaths. And then recognizing a baseline if your incentive spirometer values have now decreased. Is it because your pain is not controlled? Secondary complications from rib fractures. So we talk about if you're not taking big deep breaths, cause pneumonia, respiratory failure, chronic pain. Some patients may not have, if they required a chest tube, some blood was not drained, or they didn't have a chest tube and may have some blood that has not been reabsorbed by the body, may require drainage. So kind of moving on into a patient that we can kind of talk about. Is there a mouse? So this is a female patient in her 60s. She's a restrained driver, rear-ended at highway speeds. Upon EMS arrival, she was hypoxic, fused, GCS of 14, vital-wise, blood pressure low at 90/68, and requiring 6 liters of oxygen to maintain her saturations. Heart rate being 113. This is her admission x-ray. You can see my cursor here on the left. You can see that she has rib fractures, some of them fairly displaced. And then a right-sided pneumothorax. Kind of put into different perspective here on the admission CT scan. The front being up here and the back being here, right side and left side. So what we're looking for, this blackness on the right, is the pneumothorax. You can see the collapsing of the lung. Making its way down. Now if we change our focus to the ribs themselves, so we can change the bone window. I can kind of pause here, sorry. On the side here, you can see that some of those ribs are displaced, some of them poking into the lung. There we go. And then we also can do 3D recon, so you can see on that left side where some of those ribs are displaced. And just in regards to trauma, looking at her injury list, she does have this right pneumothorax, slight leftward shift of the mediastinum, numerous rib fractures bilaterally, left 1 through 3 through 8, sorry, right 10 through 12, pulmonary contusions in the small left hemothorax. So she was admitted, a right side chest tube was placed. Follow-up x-ray showed a decreased, very small right apical pneumo. Hospital day 2, patient's oxygen increased to requiring 50 liters at 60% to maintain saturations of 92, tachycardia up to 121. So a CT of the chest was completed. We can stop here and see that patient has a very large pneumothorax. If I can find the spot here, you can see that the chest tube is in the lung, right here. So the right chest tube was replaced, follow-up X-ray shows re-expansion of the lung. And then the left pneumo is not visualized. Heart rate improved, saturation was improved to 5 liters, 94%. The patient continued to progress. In hospital, day 5 was transferred out of the ICU. She did require neurosurgical procedure and was left intubated for that. And then following day did undergo rib plating on the left side there. So some patients are good candidates for rib plating. She was one that had a lot of pain, feeling of chest instability, really difficulty with airway clearance due to pain. A few days later, this is hospital day 10 to 14. She was intubated for respiratory failure, extubated a few days later, and chest tube was removed. She did continue to have poor respiratory effort. She was refusing to send a spirometry. Her pain was poorly controlled. Following X-ray the following day shows complete opacification of the left hemothorax, which was new. It was unsure at that time if this is blood or if this was mucus plugging, so a CT scan was completed. So looking at that, on the left side here, you see that the lung is completely collapsed from mucus plugging. So CT showed near complete opacification of the left main stem bronchus, left side airway secondary secretions, resulting in complete atelectasis of the left upper and lower lobes. So this patient, pulmonology was consulted and she underwent a bronchoscopy. Day following post-bronchoscopy, her X-ray improved, significant improvement in aeration. She was therefore encouraged to keep using IS, working with therapies and pain control. Rest of the hospital stay was prolonged just for pain control, placement, and therapies. At one point, she did require hospital day 28 thoracentesis for retained pneumothorax, and she ended up being discharged to rehab on hospital day 42. So she went through a lot, definitely a lot of different problems with breathing. The important thing, I think, is recognizing changes in your patient, and then just kind of cueing to those assessment skills that we know, the ABCs. Yeah.
All right. My name is Stacy Butts. I'm an instructor of respiratory therapy. I just celebrated my 26th anniversary at previously Minke and now Sanford. So I'm going to talk about application of the ventilator for the trauma patient. So hopefully you learn some information on ventilation today. I'm not going to try to sell you any ventilators. I'm just using them as examples. We're going to talk about indications briefly of invasive and non-invasive ventilation and talk about getting that ventilator set up, getting some initial settings on the machine, and taking a look at how your patient looks on those initial settings. For our indications, obviously apnea, acute ventilatory failure based on blood gases, impending ventilatory failure, including that Glasgow coma score for your patients, less than 8, they're at high risk of complications if they can't maintain an airway, so that might fit under that category there. And then oxygenation, if we're having a difficult time oxygenating, they're not responding, that would be another indication. So really no contraindications to invasive mechanical ventilation other than you don't have an indication. Non-invasive ventilation, there are quite a few contraindications to non-invasive ventilation, and our trauma patients may fit into one of these categories here. So, oh no, I have sound on there on my slides. Sorry about that. So phase 1 of mechanical ventilation initiation, we're going to choose the ventilator, and there's over 120 different ventilators on the market. So you really have to get out your ventilator and get to know it. Not all ventilators can do all patient populations, neonatal, pediatric, and adults. So take a look at your vent and see what its capabilities are. Same thing with the circuit. We have a neonatal circuit that we typically use up to right around 15 kilos. After 15 kilos, we move to what we call the adult circuit. The neonatal circuit is going to be a little bit more sensitive, but it does have higher resistance to it, and it has less rebreathing of CO2. The adult circuit, just the opposite. It's can handle a lot more flow, so there's less resistance, but you are going to have some rebreathing of CO2 on there, which is very, minuscule if it's an adult patient. But if you try to ventilate a baby with an adult circuit, you're going to get some rebreathing of CO2 through that circuitry. And then we have all the accessories that come with the ventilator. So the HME, heat and moisture exchanger, that we're going to use to try to preserve the mucociliary tract function. We have suction catheters, inline suction catheters, sterile suction catheters. We have elbows and extensions that we might put in line to make it easier to handle the circuit. And then on top of that, the end-tidal CO2 monitoring adapter that we put in line. There is a pediatric and a neonatal size as well. That ironically, it's to measure end-tidal, but the bigger the adapter that you put in line with the ventilator, the more rebreathing of CO2 that you're going to get. So make sure that you have the appropriate accessories to go with that ventilator. Okay. Then we're going to choose a mode of ventilation, and not all vents have a lot of choices. There are some ventilators that only do pressure ventilation, and there's some ventilators that only do volume ventilation. So the mode we'll talk about a little bit, but otherwise that is going to be based on which ventilator that you choose. We're going to get some initial settings. We really don't know what the patient's going to need for initial settings until we actually get them on the ventilator and see what it looks like. Phase 2, once we get the patient on, we're going to do some monitoring, look at what some of the feedback we're getting from the ventilator looks like and what our patient looks like on that machine. So today we're going to focus more on initial settings and our monitoring of the patient and what it looks like. But then, yes, eventually you'll get to phase 3, which is recovery and weaning, and that weaning process. Okay, so here's our case study. We have a 37-year-old male bicyclist struck by a vehicle. Patient has lacerations and contusions to the chest wall, also has a head contusion or abrasion that we're looking at. Patient on the scene was responsive to painful stimuli, but now has become less responsive in the ED. So the patient was intubated, manually ventilated. We are getting a reading on our end-tidal, so that means the ET tube is in the correct position. And you don't need a number for that necessarily. If you do just have an end-tidal CO2 detector to turn yellow, typically, there's colorimic ones that just change color to verify that you are in the correct position. We still want to verify that the patient has bilateral breath sounds and that the ET tube within the trachea is in the correct position. And we do have vital signs, a heart rate of 133, BP 89 to 42. So we have some issues to deal with. Meanwhile, we're ready to put that patient on the ventilator. And so we have to pick modes of ventilation. And across the bottom are all the different generic names for the modes of ventilation. So these modes might not match up with what your ventilator calls them. There is no universal language when it comes to modes. So again, you're just going to have to dig through your ventilator. I would say the only mode that's the wrong mode of ventilation is CPAP and pressure support. That's not something that you're going to initiate on your patient unless you're using non-invasive ventilation, right? CPAP and pressure support are very typically used for non-invasive ventilation. And then during the weaning process, we use CPAP and pressure support. But initially, we're going to choose one of the control modes of ventilation. And really, CMV is controlled mandatory ventilation, IMV is intermittent mandatory ventilation. If your patient isn't spontaneously breathing, there's no difference between the two. And then we can either choose a volume ventilation mode where we set the volume for each breath, or we can do pressure ventilation where we target the pressure of each breath. We do have smart ventilators out there that use a combination. They're dual modes where we can tell it, I want you to use pressure ventilation, but I want you to target a tidal volume for me. And the computer algorithm in the ventilator can adjust the pressure to get the target tidal volume. And on our Hamiltons that we readily use around here, it is called APV, Adaptive Pressure Ventilation Mode. That is that smart mode that you will use pressure ventilation, but to target a tidal volume. Okay. So when we set up our ventilator, you absolutely got to do the pre-op check. The pre-op check on the ventilator will tell you if there's leaks in the circuit. It'll tell you if you set it up correctly. If you put your patient on without doing that and there's alarms, you have no idea if it's your ventilator or something wrong with your patient. So absolutely got to get that pre-op check done. And that could include, if you haven't used the ventilator in a while, that pre-op check should include attaching a test lung and running it, making sure that it functions on the test lung before you put your patient on. Otherwise, on our Hamiltons, we have to select the patient population that we're going to ventilate. On our smart machine, we're going to tell it the gender and height of our patient, and it's going to tell us ideal body weight right on the machine. And then we can go to modes and select the mode that we want to use and look into what controls that we want to set up on the patient. So once we get our settings on and we've chosen our mode, we are going to attach our patient and then hit this start ventilation button. If we use this smart mode of ventilation, APV mode of ventilation, if you start the ventilator before you attach your patient, it's going to start ventilating the room. And so it's going to use a pressure of like 20, and then it's going to get this huge tidal volume back because it's ventilating the room, right? And then you attach your patient and it's still averaging that tidal volume. So it is important to attach your patient and then hit start ventilation when you're using this APV mode of ventilation. So let's look at some settings. So on this adult patient that we were talking about in our case study, we can absolutely use a rate. I would say either 14 or 16 for a rate. If you knew that your patient had been down for a while and had not been breathing for an extended amount of time, a rate of 16 might get you to normal blood gas values faster. But this patient had been breathing consistently, was just losing consciousness, losing protection of their airway. And so we know they weren't down for an extended amount of time. So we can start at a rate of 14. We're going to start here at a tidal volume of 500, which is right around 7 mLs per kilo. If you're using pressure ventilation, though, you're going to just have to pick a peak pressure of 20, 25, and then start looking at chest rise once you get the patient on. We're going to use an I time of 1, right around 1 or 1.2. We can start at a PEEP of 8. Again, if you knew that your patient had been down for an extended amount of time, maybe you want to start higher at a PEEP of 10. We have a flow trigger or sensitivity. Once the patient does start waking up, we want them to be able to trigger the ventilator. That is the most efficient form of ventilation. We don't want the patient fighting the ventilator or working against the ventilator. That's going to consume a lot more oxygen, produce a lot more CO2. So when we first put the patient on, we really won't know what flow trigger is going to work for them. But once they start breathing again, we're going to want to reevaluate that setting. We can start at 100% and then watch their sats once we get the ventilator on to see if we can wean that right away. And again, we're going to connect our patient and then hit our start button on the ventilator. So immediately in our case study, we put the patient on. We're looking right away at our patient for chest rise. In that APV, that smart mode of ventilation, it works its way up. It starts at a lower pressure and keeps increasing the pressure till we get the tidal volume that we told it we wanted. So it may take a little bit while to get chest rise. If you're not getting chest rise, take the patient back off, bag them, put the test lung on, troubleshoot your ventilator to see why you're not getting good chest rise. We do have bilateral breath sounds on our patient, but they are coarse bilaterally. Once we verify that, yes, we are moving the chest wall, we're looking up at our monitor as well. We're still getting a good end tidal reading, which means the tube is still in the correct place. Our vital signs, we look up and they're trending upward, not downward. If we had put the patient on the ventilator and their vital signs quickly trend downward, let's take them back off, bag them, troubleshoot the ventilator. Let's see what we can do there. But in our situation, patient looks good on that. So we look over to our ventilator, and if you're using a really basic ventilator, you might not get all this feedback from the machine, but our ventilator is telling us that we're using a peak pressure of 28 to get tidal volumes that are just shy of the 500 that we're targeting. But the ventilator in our situation is going to call that good enough. It's going to probably stay at that consistent pressure of 28 as long as the tidal volumes stay right around 480, 490. Again, we told that we wanted 500, but the ventilator in the situation is going to call that close enough. Our ventilators try to calculate plateau pressure, and we're going to talk a little bit about plateau pressures in a little bit. But that peak pressure and that plateau pressure are not alarming to me. That looks good. We can calculate or look at our ventilator to determine compliance and resistance to see what we're working with. Compliance is how stiff the lung is. So that's how much volume I can get in for every centimeter of water pressure that I push into the lung. So normal compliance is 70 and above. So this is a little less compliant than what is considered normal, but not the worst I've ever seen. And then resistance is how much pressure I create when I push 1 liter of flow into the lungs. And so normal resistance is 10 or less. Again, 16 isn't the worst I've ever seen, but it's not necessarily normal either. One of the things that could help with this scenario is to suction. Obviously, we have bilateral coarse breath sounds, and maybe if I suction, I might get some improvement in my numbers there. But otherwise, if I saw this on my ventilator, I saw this is how my patient looked on the machine, I would be happy with that. I wouldn't make any changes at this point other than suctioning. In this particular patient, we were suctioning blood when we cleared those secretions. I'm going to immediately, even though I'm happy with everything that I see, I want to set up my alarms, not just to tell me if something catastrophic is happening, but I want the machine to warn me, if at all possible, if there's changes, good or bad. If my lung starts to get stiffer, I want to know that. If my lung is getting better, I want to know that because I don't want to hyperventilate them. But probably within 30 minutes, I want to get a blood gas to see where I am at with those vent settings that I picked. So most ventilators have a high pressure limit that you want to set. So typically we're going to set the high pressure limit 15 above the current peak pressure that you're using. That way I don't want to automatically set it at 50 or 60. I really want it to warn me if there's any changes. And then not all ventilators have expiratory minute volume alarms or tidal volume alarms, but on our particular ventilator, we do have the option of, we're going to set it about 50% above and below what our current minute volume is. The frequency total, right now I shouldn't have to worry about that because my patient might not immediately be breathing spontaneously, but right around 40, I want it to warn me. Tidal volumes, occasionally when a patient takes 2 breaths in really quick, it'll alarm high tidal volume. So that's why if they double trigger the ventilator, I don't necessarily want it to alarm for that reason. So I will set the upper tidal volume alarm at double what is set. The low tidal volume alarm, obviously I said that I wanted 5 mLs per, or what did we decide, 7 mLs per kilo. So I want to for sure be at least 5 mLs per kilo before it starts alarming. Apnea time, we're on a control mode, so I'm not too worried about that. Some of our ventilators have this little auto button that'll automatically set your alarms for you. They are really tight, so typically it does result in alarms going off. So we might make some adjustments there. Okay. On that high pressure alarm, if you happen to be using the Hamilton T1, C1, G5, that high pressure alarm can kind of be confusing. If we're getting a peak pressure right around that 29, and we said we're gonna set the high pressure alarm 15 above that. The vent didn't do that. The vent didn't cause this high pressure alarm. This is the patient more than likely coughing or fighting against the machine, because the ventilator is going to say, okay, in this APV mode, I'm not going to purposely give a breath that's actually 10 below that peak pressure that I told it couldn't go above. So it's a little bit confusing. So there's a high pressure alarm that will go off when the patient's coughing. The high pressure limit set, what it's trying to tell you is that, okay, you wanted 500 and I can't give you 500 of tidal volume because you told me I couldn't go above a peak pressure of 30, for example. So that's why you get a yellow alert alarm. So these are both audible alarms, but the pressure limit yellow alarm is just going to go beep beep, and then it's going to be silent for a few minutes, and then beep beep to remind you that, okay, you wanted 500, but I can't do it. So I'm just going to keep reminding you that your tidal volume is a little low. So in that situation, I have to choose, do I want to let it use a higher pressure, or do I want to accept a lower tidal volume to get rid of that alarm? Where with a high pressure alarm, the red one over here, the patient coughing, that is more likely the patient needs to be suctioned. Okay. When would I make adjustments? What would make me start making changes? So if I start to see my peak pressures going up, I really want to be able to measure plateau pressures, because peak pressures are really measuring the pressure in the circuit and not in the lung. The highest point of resistance is when that ventilator hits the hub of the ET tube. That pressure kind of rebounds in the circuit. So the peak pressures in the circuit are typically higher than the pressures that we actually get into the lung. So the plateau pressure is how much pressure that we're actually applying to the lung. A true plateau pressure measurement, I would give a breath in and the exhalation valve on the ventilator would close, so it's holding that breath in, and then we're allowing the pressure to equalize between the circuit and the patient. And that will give me a better idea of how much pressure is actually reaching the lung. So plateau pressure, if I see really high peak pressures, that's going to clue me in to take a look at my plateau pressures on the ventilator. If they are greater than 28, I'm going to start to drop that tidal volume target by 1 ml per kilo, making sure that I'm at least 4 mLs per kilo of tidal volume. Under 4 mLs per kilo of tidal volume, I'm going to start to just ventilate the trachea. I'm not going to provide alveolar ventilation with tidal volume smaller than that. So some things that can cause really high peak pressures but low plateau pressures include really small ET tubes, mucus plugs, the bronchospasm could cause that as well. Okay. And again, at that, if they have high peak pressures and low plateau pressures, I'm not as concerned about that. We're not applying that really high pressure to the lung. But in the situation where I have a high peak pressure and the plateau pressure isn't too far underneath that, that is like ARDS, atelectasis, pneumothoraces, pleural effusions, air trapping that would cause that. And that is something that, again, I would want to start dropping the tidal volume possibly in this situation to get that plateau pressure less than 28. Okay. Some other ventilator adjustments. So if I get that blood gas back, my target is to keep the pH greater than 725, CO2 is 35 to 55. I do want to make sure that if I'm getting the peak pressures that I like, that I'm changing the rate to get the blood gases that I want from that, from those settings. But as I increase the rate, I do need to make sure that they're exhaling all the way between each breath. So the top waveform shows the ventilator delivering a breath on a flow waveform, and then the patient exhales all the way out before the next breath goes in. If I'm in this situation down here where I'm giving a breath, the patient starts to exhale and they don't exhale all the way to baseline before the next breath goes in, that's breath stacking. And eventually we're going to get really high peak pressures with that. The CO2 is going to go up. So this patient, we can't go faster on the rate. So we're going to have to go higher on the tidal volume and slower on the rate to give them more time to exhale. One of the most challenging patients to ventilate is a patient with a huge chest tube leak, because that ventilator doesn't understand where all that volume is going. You're telling it, I want a tidal volume of 500, and the ventilator isn't getting that back from the patient, that we're giving a big tidal volume in, it's going somewhere other than back to the vent, and the vent can get very confused by that. So if you do have a really large chest tube leak, or you don't have a cuffed ET tube and you have a leak around the ET tube, if you have more than 25% of a leak, you are going to want to get out of that APV mode of ventilation and use just a straight up pressure volume mode of ventilation. It can't target something that it can't measure, right? So that gas is escaping. In cases where we have really large leaks, we typically see the CO2 get really low on us. We can see, a PCO2 of like 15, 20, because the ventilator is trying to maintain PEEP, and it's just going all out the chest tube, and the CO2 is coming out with it. So first of all, we try to use, minimal rates, minimal tidal volumes, like we've been talking about, but also you might in the end have to lower PEEP to get your CO2 to normalize in that situation. Adjusting PEEP is super important. We need to recruit that lung, keep it open. If you want to prevent mucus accumulation, you want to prevent mucus plugs, you want to prevent lung injury, you need to have optimal PEEP. So we know that some of our patients require a significant amount of PEEP to maintain open lung volume. We can adjust PEEP based on chest x-ray. If I get an x-ray and both lungs are hazy, I know I can go up on my PEEP by at least 2. If I get maybe just a little haziness on one side, go up by PEEP by 1 and see how that looks. We can do incremental increases in PEEP based on FiO2. So I can go up on the PEEP, and if that means I can wean my FiO2, great, go up again. Keep going up on PEEP until you notice that you're not able to wean FiO2. If you have a ventilator that can measure some lung compliance, again, as long as you go up on your PEEP and your lung compliance is getting better, that means you're going the right direction with your PEEP. If you go up on your PEEP and all of a sudden your lung compliance falls, then you know you went too far. Optimal PEEP, we do have to talk about, let's say this is a patient that we're concerned about intracranial pressures, we're concerned about impeding venous drainage. We can't be completely afraid of PEEP and just go, well, we're going to use 0 because we don't want to impede venous drainage. Well, too low a PEEP is going to impede venous drainage, and too high a PEEP is going to impede venous drainage. So this slide is kind of a busy slide. If you look at the bottom of this graph, PEEP is along the bottom. So very little PEEP is down at this end on your left-hand side. High PEEPs are on the right side. If you look at the left side going up, this is lung compliance. So at really low PEEPs, you're going to try to be ventilating a very stiff lung. You're getting at high peak pressures, high plateau pressures. That will result in impede venous drainage. As you increase PEEP, the lung is going to become more compliant and easier to ventilate, and you're going to be able to use lower mean airway pressures, which will improve venous drainage. If you go too high in your PEEP, though, yes, now again, you're going to be impeding venous drainage because you're trying to ventilate a lung that's way too far expanded. On the right-hand side is pulmonary vascular resistance. So if you have high pulmonary vascular resistance, it's not going to want to let blood flow through the lungs. So at low PEEP, you have high pulmonary vascular resistance. As you open up that patient and prevent atelectasis and treat atelectasis, you're going to recruit more lung, pulmonary vascular resistance is going to improve, and again, your venous drainage will improve as well. Okay, but again, if you keep going up on PEEP and all of a sudden you're needing more FiO2, you probably went too far on this graph, and now you will have issues with venous drainage. All right, any other questions? Are we posting any questions online?
At the end, we can
Okay.
put some in
Okay.
the chat box.
Sounds good. So what are we going to do different for your pediatric patients? We're going to use slightly different rates, and these are really big ranges for what you're going to set for a rate. It is very traditional in pediatrics to use an SIMV mode of ventilation. If they're not spontaneously breathing, we're just setting that rate really high. And then as they start to take over ventilation, we can wean that towards ventilator liberation. But we're going to start higher on the rates. If you want to start kind of in the middle of these ranges, and then based on blood gases, you can go up or down from there. That works. We're still going to target 6 to 8 mLs per kilo ideal body weight. Again, if you were having really high, it's really hard to measure plateau pressures on babies and kids. Compliance and resistance numbers that I was talking about before are not really relevant. The numbers just aren't the same. Compliance and resistance, you can trend it to see if the number is getting bigger or smaller, but that isn't as useful in kids. To just the absolute number doesn't necessarily make sense in the moment. So it is something that you would have to trend compliance and resistance. But again, if you're getting really high peak pressures and high plateau pressures, if you can measure it, then yes, we could go down all the way to 4 mLs per kilo. But again, you wouldn't necessarily start right away at 4 mLs per kilo. PEEPs anywhere from 5 to 12. Again, if you want to start at 8, that would be a great place to start, and we can see how that looks once we get the patient on. Eye times are going to be a little bit shorter, more like 0.6 to 0.8 seconds. Once they do start triggering the ventilator, if they're breathing over that mandatory rate, then we have pressure support breaths that are going to kick in. And again, make sure that those pressure support breaths are at least 4 mLs per kilo. Otherwise, if those pressure support breaths are too small, it's really just going to make them super tachypnic and air hungry. So make sure that whatever you're setting for pressure support is adequate as well. Okay, otherwise, here's my references. These top 2 articles are really good if you want to look into those, really focusing on that first hour for the trauma patient, what should you do differently for ventilation. A lot of my pictures and slides came from my textbook on the bottom reference, but that is all I had for you today.